Welcome to this overview of a poster entitled Early Experience with Broad Panel NGS Testing for Kidney Disease in a Community Nephrology Setting. This was presented at the American Society of Nephrology Kidney Week 2021. Authors include Dr. Tarek Darwish of Kansas City Kidney Specialists, myself, Katya Brossart at Natera, as well as Dr. Hossein Tabriziani, also of Natera. This is the poster in its entirety as it was presented recently at ASN Kidney Week, and in the coming slides, I'll walk you through each of these sections. To provide some background for this case series, in spite of increasing awareness among community nephrologists of the potential value of incorporating genetic testing, its adoption is still somewhat limited. We are seeing over time that genetic testing can provide a number of benefits in this setting. So it can enable better prognostication. It can allow for, in some cases, targeted treatments, and definitely referral to specialists for the extrarenal manifestations very frequently identified through genetic testing for kidney disease. Also, it allows for identification of relatives at increased risk of kidney disease themselves based on these findings. And for patients with kidney failure, there are additional benefits of being able to better assess the risk of recurrent kidney disease after transplant, and also to inform decision-making about who in the family may be a suitable living-related kidney donor. We are seeing in the recent literature that broad panel testing can provide significant benefits in terms of increased yield and better identification of underlying genetic etiologies as compared to more narrow panels that are based on clinical presentation or features. In all, 31 patients with kidney disease were selected for genetic testing with the Renasight panel, a more than 380 gene kidney disease panel using next-generation sequencing. Patients with any of the following criteria were offered testing: chronic kidney disease with unknown etiology or end-stage kidney disease, chronic kidney disease with only hypertension as a comorbidity, patients with hematuria who had not yet had kidney biopsy, those with underlying chronic kidney disease, hypertension, and either well-controlled diabetes or no diabetes, those with relapsing proteinuria or nephrotic syndrome, and lastly, those with resistant electrolyte abnormalities. Positive findings for these patients included monoallelic pathogenic or likely pathogenic variants in an autosomal dominant or X-linked gene, or biallelic pathogenic or likely pathogenic variants in a gene associated with autosomal recessive inheritance. Looking at the results of testing, positive findings were identified in 7 of 31 patients tested, or about 23%, and testing had implications for prognosis in 6 of those 7 patients, or about 86%. Additionally, there were changes in clinical management informed by testing in 2 out of 7 patients, or about 29%. Lastly, about 10% of patients, or 3 out of 31, were found to be homozygous or compound heterozygous for the APOL1 high-risk alleles G1 and or G2. These were patients who were primarily self-reported as having African American or African ancestry. To review the genes associated with these positive results, we see that 3 of these patients had positive findings in the APOL1 gene associated with susceptibility to end-stage renal disease and focal segmental glomerular sclerosis type 4, and this follows a complex inheritance pattern. There was 1 patient identified with a Col4 alpha 4 finding associated with Alport syndrome following an autosomal dominant or autosomal recessive inheritance pattern. In addition to that, there was 1 patient with a positive finding in the PKD1 gene associated with polycystic kidney disease following an autosomal dominant pattern, and one patient with a finding in the PKD2 gene also associated with polycystic kidney disease and also following an autosomal dominant inheritance pattern. Lastly, one patient had a positive finding in the SLC2A9 gene associated with renal hypouricemia type 2 and following an autosomal dominant or autosomal recessive pattern. In conclusion, this early experience of a community nephrology practice's incorporation of genetic testing into routine care found that both pre and post kidney transplant patients identified as being at increased risk of monogenic kidney disease benefited from a broad kidney disease panel, which showed a relatively high diagnostic yield in this setting. Genetic testing can potentially identify family members who may be at increased risk of kidney failure themselves, can influence kidney transplant donor selection, and also may enable early diagnosis and better disease management. Thank you.